Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school. And now here's your host, Patrick Beeman.
All right, so we're back with our Addiction 101 series, and today I want to welcome Dr. Christopher Blazes, who is, YouTube famous. I don't know if that's really the case, but I would say his benzodiazepine use disorder lecture that is available on YouTube, and which we will link in the show notes here, is one of the best sort of summaries of benzodiazepine addiction, which is a huge problem and becoming even huger. But I asked him onto the podcast to discuss this sort of topic, and especially the neurobiology of addiction and recovery. And I'd just like to welcome you, Dr. Blazes.
Well, thank you for having me, Patrick. It's great to be here and to be a part of such a cool thing that you're doing here on this podcast.
You're welcome. No, thanks for giving up the time. And, full disclosure, the thing that got me really with that presentation that's out there from some U of M, I think, sponsored event, was you cited Plato and Aristotle and Aldous Huxley and a bunch of other things that don't usually get cited in medical lectures. I wish I weren't in my basement, because I would show you in my living room where I usually set up. I have a huge print of the School of Athens over my mantle. So I think you'd appreciate that. Yeah, no,
that's great, because I put a picture of Plato and Aristotle at the beginning of all of my controversial lectures, because they're two of the most brilliant thinkers of all times. They were contemporaries. It's hard to argue with any of their assertions, but their opinions were often opposed. So when there's controversial issues in medicine and in giving lectures, so I often invite the audience and just to remind myself that if I identify more with Plato, that there's an Aristotle out there who's equally as well informed, and I could probably learn something from.
Intellectual humility. I think they both learned that from Socrates.
True. Yeah.
So Socrates, as you know, was famous for, or his reputation was significantly centered on the fact that he knew what he didn't know, which is a great virtue for a physician as well. But before getting into all of this, I'd like to know who Dr. Christopher Blazes is. So you give me a little bit of your background, where you're at in terms of your career, what's important to you, et cetera.
Sure. So I'm a little bit of an oddball. I'm a board certified emergency medicine doc, but then a little bit later on in my career, I also decided to do a second residency in psychiatry. So I'm also a psychiatrist, and then I did a fellowship in addiction psychiatry. So right now I'm on faculty at OHSU in both psychiatry, addiction psychiatry, and emergency medicine. So I spent a good number of years in the community and kind of made my way back to academia, which was an interesting transition, but I'm glad that I did. And just for your reference, the lecture that you're referring to is actually, if you look it up, it's on the UCSF sponsored website.
Oh, gotcha. Okay. Yes. And reminder, we will link to that. So, well, that's awesome. That's probably another conversation, but as somebody who is now doing private practice and really loved academics and thought, way before med school that I'd wind up in the academy, I often fantasize about going back to the academic setting, but I get some of the teaching and intellectual kind of stimulation from doing this podcast. But good on you. I bet that was tough to kind of get back into that world, especially, man, that is pretty diverse. Emergency medicine and psychiatry and addiction psychiatry. What was the interval between getting done with your emergency training and then going back?
I finished my emergency medicine residency in 2001, and then I continued practicing emergency medicine up until just recently. I just recently stopped. So I continued to practice throughout my second residency in psychiatry. And then I retrained in psychiatry around 2013. And so it was after the second residency that I went back into academia.
Okay. All right. Well, what we usually do on the podcast is do a little review of some questions to help students study on the go for their board exams. So let's do a couple of these thanks to Amboss. And the first one is going to be asking which of the following is the most likely effect of this drug on the synaptic cleft. And the vignette has it that an investigator is studying a local anesthetic that activates both alpha and beta adrenergic receptors. When given intravenously, it causes euphoria and pupillary dilation. Which of the following is the most likely effect then of this drug? A, increased release of norepinephrine. B, decreased breakdown of norepinephrine. C, decreased reuptake of norepinephrine. Or D, increased release of serotonin. If you were to go back for a third time into medical education, or a fourth time and become a medical student again, how would you think through a question like this? Are you the type of person who just goes for the answer? Do you look at every answer choice before committing? What's your process?
So my process, it's interesting that you bring this up because when I used to think things through very completely and thoroughly, I never scored that well. So for me, the way that my brain works is I'll read the question, I'll read it through thoughtfully once, and if an answer comes up, then I go for it. If I don't know the answer, I'll read through it a second time and try to go about it try to think about each part more closely. But I will not spend a large amount of time trying to figure it out, because I've grown to trust my unconscious mind more than my conscious mind.
Yeah.
And we're getting more philosophical again. But I think that in the Western world, we're so, and this is like more Aristotelian than Plato, we're so focused on the intellect. But I think that there's powerful parts of our brain that we use less.
Yeah.
So I tend to move towards the unconscious.
I call it the hunch reflex. That sort of like, I think that's it. Boom. Going to move on, make the answer choice and move forward. So,
well, yeah, I mean, it's called different things by different people. I think, Malcolm Gladwell called it the adaptive unconscious. Silvano Arietti is a classic psychiatric analyst who called it tertiary processing. So I think that once the knowledge is in there, there's a part of us that is able to kind of, use it more effectively.
All right. So we've got this drug then the investigator's looking at. They give it IV and it causes euphoria and pupillary dilation. So they want us to know or answer which of the answer choices describes the effect of the drug at the synaptic cleft. And the correct answer here, just to be clear for the students, is decreased reuptake of norepinephrine. And I guess what I would ask you to do, if you don't mind, are you able to kind of break down what happens with this particular drug, which is cocaine, in terms of its activity at the synaptic cleft?
So, yeah, cocaine is one of the classic stimulants that we know about in addiction medicine and addiction psychiatry. And when people ingest cocaine, it ends up decreasing the reuptake of norepinephrine, but also other monoamines in the synaptic cleft. So, and that differentiates it from, for example, methamphetamine, because not only does methamphetamine decrease the reuptake of norepinephrine, but it also increases the release of norepinephrine from the stores in the cell. So it kind of has a double whammy of activity with methamphetamine versus cocaine. And that's a good board question to remember as well.
Say that again, then we'll pause. Just restate that then. What should they remember between cocaine and methamphetamine as stimulants?
Sure. So cocaine, the mechanism of action is that it decreases the reuptake of monoamines, which are norepinephrine, serotonin, and dopamine. So all three of those. And methamphetamine is more powerful than cocaine, and think of it that way, because it does that. It decreases the reuptake so that the monoamines stay in the synaptic cleft longer, but it also facilitates the release of the monoamines from the cell stores. So you not only are you slowing down the reuptake of it, but you're increasing the release into the synaptic cleft. So it's much more powerful. And it's also clinically relevant in the sense that a lot of the prescribed stimulants fit into those categories as well. Like, for example,
that was my next question. What about regular old amphetamines?
Exactly. So, Ritalin, for example, is just like cocaine. Its mechanism of action is that it decreases the reuptake of the monoamines. But Adderall, for example, is like methamphetamine. It does both. And so that's kind of a very important clinically relevant piece of knowledge to know that also probably is good to know for the boards.
How would you differentiate methamphetamine then from like the Adderall, which is mixed amphetamine salts, right? Is there a significant mechanistic difference there?
Virtually none.
Okay.
And that's also, I think, clinically relevant because, in my opinion, and the opinion of a lot of people who are smarter than me, like Adderall, for example, is much more abusable than Ritalin because it is much more powerful. So it's also, Adderall will turn a drug screen positive for amphetamine, whereas Ritalin won't.
Got it.
Same exact mechanism as methamphetamine.
Now, the first answer choice, which I would say is probably the most attractive distractor, as it were, is increased release of norepinephrine. So I think you covered that by stating that whereas cocaine, increases the concentration by blocking the presynaptic reuptake of the monoamines, the methamphetamine, amphetamines of this world as stimulants increase the release of the monoamines. So if you wanted to choose A, we've covered that, and you know why it's not A instead of C, decreased reuptake of norepinephrine. But what about this? Would methamphetamine, amphetamine, cocaine, Ritalin, are they all going to cause euphoria and pupillary dilation?
Yes, to varying degrees. The euphoria aspect is a little bit, it's hard to generalize completely because, some people become dysphoric on stimulants. So, and this is, we're getting into the realm of being very specific, but like for the board's purposes, they're going to say it will cause euphoria. But in actual clinical practice, for certain people, stimulants can cause dysphoria.
Now, I think then the key to this question then is to pay careful attention to the vignettes, because what is asked or what is stated is that an investigator is studying a local anesthetic that activates both alpha and beta adrenergic receptors. So methamphetamine, amphetamine, these are not local anesthetics, but you should know that cocaine is in the class of local anesthetics. Is that a fair thing to say?
Yeah, that makes a lot of sense. And we continue to use it a lot in emergency medicine for nosebleeds and such.
Oh, really? Okay, makes sense. All right. So, anything else to note for these answer choices? Decreased breakdown of norepinephrine was choice B. That would be like the MAOI inhibitors, which I don't think those are really abused, right?
No, never seen it.
And then increased release of serotonin. This is probably worth mentioning, choice D. So LSD, MDMA. What is the difference between, say, or what can we say about LSD or MDMA versus cocaine or other stimulants like cocaine?
It's kind of hard.
I mean, a lot probably, but
yeah, I mean, but to make a generalization, it's really hard. And this is, these chemicals and how they affect the brain, it's actually much more complicated than we describe, because it affects multiple different areas with multiple, because actually LSD and MDMA, it's not entirely serotonin. There's other receptors involved. But in general, I think that it's more serotonergic than than the other stimulants. So there is some stimulant activity, and I would say that MDMA and LSD do result in some other monoamine activity, but it's predominantly more serotonin.
Now, can you get hallucinations on all of the stimulants? Because LSD, I think, if anybody knows anything about someone like Steve Jobs or, I don't know, tons of music from the 60s, 70s. I just watched a Woodstock documentary. We know this causes hallucinatory activity. Is there a described mechanism or good heuristic to understand why LSD characteristically causes these visual hallucinations versus the others, which, or MDMA classically has that party sort of club drug. People want to dance and feel close to each other and all this stuff.
Yeah. And again, I think this is where we're kind of in our adolescence of understanding of these medications and adolescence of our understanding of the brain. It's so complicated. And so there's some certain trends that we've noticed through research and it being kind of, validated over time through other people, such as the fact that MDMA and LSD are more associated with serotonin, but the mechanisms are so much more complex than we understand, because it's also a really hard thing to study, right? I mean, getting your IRB to approve studies like this is really, really challenging. So there's so much more we need to know. I wish I could give you a better answer.
Yeah, some of that was tongue in cheek. For the board's purposes, I would say it's probably good we're in our adolescence for the medical students, because
exactly
they're not going to ask things that will require a lot of distinctions. Essentially, I would say it seems to me like the sorts of information, the kind of information that's covered is more heuristic almost, or archetypal. In terms of what they're asking about drugs or their mechanisms of action, just because they usually illustrate some good concept that's applicable across, all of medical education. But let's see. So before we move on, though, I got one question about everything that's been mentioned thus far, as far as substances that are abused go. So amphetamines, methamphetamine, cocaine, LSD, MDMA. Is there an inherent property to these drugs that would make one, quote, addictive versus another? Because I don't hear too much about people being addicted to something like LSD versus cocaine.
So we have pretty good knowledge of this. What defines a drug of abuse is if it causes dopamine to be released in the nucleus accumbens, which is kind of the center of the reward circuit. And that all drugs of abuse will do that, either directly or indirectly. So even drugs that aren't involved with dopamine, through pathways in the brain, through feedback and negative feedback and activation, will end up resulting with dopamine release in the nucleus accumbens. So I think you're right. It's, LSD is classically thought not to be addictive, and I would agree with that statement. And there is no evidence that it does end up with resultant dopamine release in the nucleus accumbens. I think that gets after what you're talking about.
Yeah, I think that's a good, especially touching too on neurobiology as was going to be our topic. All right, we'll move on from the stimulants there, and then let's do another one that I'm sure is a favorite of the boards, and especially, and probably your emergency medicine shelf exam, and probably a bunch of other things too. So the next one we've got, which of the following would most likely reverse this patient's condition? So we're looking for essentially an antidote. And the vignette has a 23-year-old woman comes to the ED 30 minutes after being found unresponsive by her boyfriend. The EMS found empty pill bottles next to her, and her boyfriend reports she has a history of insomnia and generalized anxiety disorder, and that she was recently diagnosed with depression. Her vitals show a temperature of 36 Celsius, which is 96.8 Fahrenheit. Pulse of 64, respirations are decreased and shallow, and blood pressure is within normal limits. On examination, she does not open her eyes. She makes incomprehensible sounds and extends her extremities when a painful stimulus is applied. Her pupils are 3 millimeters and reactive to light. Corneal reflex is normal. Gag reflex is absent. There is diffuse hypotonia and decreased deep tendon reflexes. Otherwise, she has a normal cardiopulmonary examination and is intubated for airway protection and mechanical ventilation, and infusion of intravenous fluids is begun. So kind of a lot of information in that vignette. But all right, answer choices here are A, to answer which of the following would reverse this patient's condition. A, hemoperfusion. B, flumazenil. C, fomepizole. Or D, sodium bicarbonate. So I guess the first thing is to go back to this vignette and, ask ourselves, what did she most likely take if we're getting in, what's the antidote question? I don't know. Would you walk me through how to think of what's in this vignette if I'm a medical student and I'm on the margins watching the ER doc receive this unresponsive patient being told she's got pill bottles next to her on the floor where she was picked up. What's your kind of process?
So my process as a medical student who's taking an exam would be different than as an ER doc. I'll do both.
Right.
As an ER doc, I would jump straight to the pupils. And because with somebody who is a suspected overdose, and they're minimally responsive with shallow respirations, you have to differentiate whether it's opioids versus other sedative hypnotics and things like that. And the pupils are a key aspect here. And so you also have to know what's normal, what's a normal pupil size. I think that's a very important thing to know for the boards. And 3 millimeters is a normal pupil size. So if they said 1 millimeters, then obviously that's less, but sometimes they'll just say pinpoint, but also know that 5 millimeters is a dilated pupil. So with a normal pupil size, you can pretty much rule out that it's opiates.
Okay.
And once you've ruled out opiates, then you start to consider other sedative hypnotics. And then what I would do is I would go back up towards the history and, look at the question, it says that she has a history of insomnia and generalized anxiety disorder. And so what are some of the things that are commonly used to treat anxiety and insomnia? Benzodiazepines are number one.
Yep.
And so the combination of those two things, I would be pretty much keyed into what they're looking for. And I think the last thing is that the key to know about benzodiazepine overdoses is that their vital signs are often very normal, but they'll be deeply sedated. So I think all of those things fit in here, and that's probably enough to answer. And one other thing is I also like the way that they phrased it. Which of the following would most likely reverse this patient's condition? And the answer is flumazenil, of course, which is a GABA antagonist. But in reality, I have never in my 20 years as an ER doc given flumazenil. It's something
I've heard this a few times, and it blows my mind because it shows up in, every single kind of board review. It's funny.
Yep, it totally is funny because they expect you to know it. And the reason is because you can actually cause seizures, which are refractory to many different medications. So if people are physiologically dependent upon benzodiazepines and you give them flumazenil, they're going to have seizures and you're not going to be able to stop them. If it's an isolated overdose, then where they had not been physiologically dependent, you probably will not precipitate seizures. And so knowing that in conjunction with the fact that all you have to do is basically support their breathing. So you can put them on BiPAP or intubate them and get them through it. And there's really no other significant, complications from benzo overdoses that as long as you support their breathing, they'll do fine. So yes, for the boards, no, it's flumazenil. For actual practice, I've never given it. And actually, I don't believe any of my colleagues have ever given it either.
Yeah, I do think you're like the second or third physician who would potentially use this medication based on your specialty. Over the past 5 years that I've talked to, is like Yeah. Never use flumazenil. So, just keep that in mind that when you're stressed out, but all the things you have to know on the boards, as long as you get through, very often you don't have to really worry about some of the more esoteric almost things, and you can worry about real life and taking care of patients.
Yeah. One more thing about flumazenil, just because even though I have never used it, like there's actually some interesting research about using it after people have been, successfully treated for benzodiazepine withdrawal and they're outside of the window of acute withdrawal. The theory is if you attach an antagonist to a receptor, you're going to force the body to go back to its old homeostatic state. Because what happens is with chronic suppression, with chronic activation of a receptor over time, the body down regulates. And so that often will lead to this post-acute withdrawal syndrome, which is very prevalent with benzodiazepines and alcohol and other sedatives, because it takes the body 6 months, even a year, to get back to its normal state and to have their receptors normalize. And if you attach an antagonist, then you're kind of doing the opposite, and you can force the body to work through the pause. Anyway, esoteric knowledge, but it's kind of cool and fun.
Yeah, something to think about too. So flumazenil being investigated to be the naloxone, naltrexone of benzodiazepines, essentially.
Yep, exactly.
Cool. Very cool. All right. So I think this question's pretty clear that it's going to be flumazenil just because this shows up so often. But a couple questions for those who don't know. A corneal reflex is normal and a gag reflex is absent. Any comment on that?
So I think that what they're getting at is that benzodiazepines are muscle relaxants. And so it's probably more likely that it would diminish the gag reflex. But to be honest, I'm not 100% sure. What are your thoughts?
No, I same. I have no idea why they made that distinction. I think that's that's probably it. They're probably just making it absolutely clear that this is a benzodiazepine related intoxication.
The corneal reflex is oftentimes spared. Like the ocular muscles are sometimes the last to go when it comes to decreased tone. So maybe that is what they're getting at, but I'm not 100% sure.
And what about extending her extremities when a painful stimulus is applied?
So they're almost certainly referring to decerebrate posturing, which is a pretty advanced sign of dysfunction in the brain, right?
Yep.
Normally it goes to, initially with decorticate, and then it progresses to decerebrate, oftentimes more when you're getting, to the stages of herniation. So I have not seen decerebrate posturing myself in benzodiazepine overdoses. So I was a little curious about that, but that's what they're referring to.
Yeah, me too, especially with a normal pulse, and the respirations aren't terrible.
Right.
But at any rate, sometimes questions are not perfect. But I think this one, well, you know what, too? Real life is not perfect, especially clinically. The boards do try to take a very gray sort of thing, clinical medicine, make it black and white. So if there's some confusion in the physical exam findings here, that's because there may be some confusion in real life. So we will move on. Flumazenil is a benzodiazepine antagonist or a GABA A receptor antagonist. Let's do one more here. This one should be easy, having discussed what we have thus far. So the next one's, which of the following is the most likely cause of this patient's symptoms? That's the lead in. And our patient's a 46-year-old man brought to the ED for altered mental status. He was found on the floor in front of his apartment. He's somnolent but responsive. His pulse is 64 beats per minute. Respiratory rate is 15 per minute. Blood pressure is normal. On physical exam, alcohol is detectable, and slurred speech are noted. Neurologic exam shows diminished deep tendon reflexes bilaterally and an ataxic gait. The blood alcohol concentration is 0.04. It's got a normal EKG. So which of the following is the most likely cause of the patient's symptoms? We have A, cerebral ischemia, B, ethanol intoxication, C, opioid intoxication, or D, benzodiazepine intoxication. So probably on this one, I would think the two most attractive answer choices would be ethanol intoxication, just because the detection of alcohol on the patient, the smell of alcohol, and then answer choice D, benzodiazepines, just because just because we just discussed it. And also it tends to present, I would say physically, exactly like alcohol intoxication, correct?
Yeah, it's almost indistinguishable. I mean, one thing to know also for the boards is that alcohol is a much dirtier drug than we think. It has significant GABA A activity, and that's its primary activity, but it also affects the cannabinoid receptors, the serotonin receptors, the norepi receptors, and so it's a really dirty drug. But I think the point about this question is to know like the blood alcohol concentration. So in this case, it's 0.04, which is basically the equivalent of having 2 drinks, and the level of intoxication that we think of legally that could actually get you a DUI is 0.08 or above. And if somebody was having significant altered mental status, then their blood alcohol level would certainly have to be almost certainly well above 0.08.
I have a patient in my clinic at the opioid treatment program who came in with smelling of alcohol, and so we did a breathalyzer on him, and we repeated it twice. His BAC or his breathalyzer showed, I think it was 0.43, and
shocking.
He was walking, he was talking, he was clearly intoxicated, but I thought that would be like a lethal level of alcohol.
Yeah. I mean, in emergency medicine, if in a naive patient, that very possibly could kill somebody. They would certainly be obtunded and unable to walk or move or open their eyes in a naive patient. But it's remarkable how the body adapts to chronic, substance use, because it creates counter-regulatory measures, and this is kind of ties into a bit of the neurobiology. So if you chronically have a depressant activity, which is what the GABA-A receptor is, it's a chronic depressant to the system. It slows it down. It slows down the system. But whatever's running the show inside us, some people call it the ego, I don't know, whatever you want to call it, that's modulating and controlling all of your psychic and physiologic and intellectual processes to give you a competitive advantage. Whatever's running the show counteracts things when it finds that there's a problem. So if you're taking something and you're sedated, then whatever inside is running the show will say, hey, wait, you need to be able to escape from this tiger, and you need to have more capacity to act and to move. And so it's going to increase the counter-regulatory hormones, the fight or flight response, the norepinephrine, over time. And so then at a baseline have elevated norepinephrine and glutaminergic tone, then this is the genesis of the withdrawal syndromes, right? Because if you normally balance your heavy alcohol use with a counter-regulatory neurotransmitters, you take away the alcohol, then you're just left with this overactive fight or flight response, and that could be dangerous.
Now, I think hopefully not everyone who's listening, but many who have listened have probably woken up the next day after having too much alcohol to drink at some point and felt anxious, keyed up, certainly dehydrated, have a headache. That in large part then could be thought of as a response of hey, I'm putting into my body something depressant, as it were, and then you release the norepinephrine, these noradrenergic compounds. Those are kind of still being spit out into the body as the alcohol is metabolized and goes away. Is that
yes?
Everything is so complex, but I'm sure. But nevertheless,
that's a good summary.
I'd imagine that's a good way to kind of remember this mechanistically.
Good way to summarize it.
All right. So this one was benzo intoxication, because blood alcohol, the legal limits or the intoxicated limits. Well, I guess we could comment on this. So you said that 0.04 is essentially 2 servings of alcohol, and the legal limit tends to be 0.08. I don't know if that's the same in every state, but I think on military bases, if I recall, it's a little bit lower, but so goes that. But something to remember is that the definition of binge drinking probably ties into this a little bit too, correct? Can you speak to that? 2 drinks is not binge drinking, even though that might make my blood alcohol concentration 0.04. I'm not really going to be in a binge territory as a man until I'm at a theoretical legal limit or 4 drinks or more, correct?
Exactly. And so that is the definition of binge drinking. And this is a very ripe question for the boards. So anybody who drinks to the point where their blood alcohol level is greater than 0.08 or intoxication, that qualifies as binge drinking. So that's a great point.
All right. So let's get into more the meat of the neurobiology of addiction and recovery. So a lot of people don't realize how prevalent I think addiction is. And in many respects, that's why we're doing this series. But the prevalence is so high, I assume, because it's super easy to mess up your, brain's reward system and become addicted to a substance. How does that happen? Like, why, if I take a Percocet after getting a hernia repair, do I, get nausea and think it's terrible and not want to use it? And then another patient likes it, gets dependent, and why does one person get addicted and not another person?
Well, I think that what you brought up was such a great description. You take a Percocet and it makes you feel nauseated. You're like, why would I take this? And another person takes it and it activates them and it gives them euphoria. And, interestingly, this hasn't really been documented in the literature, but when I am treating people who are addicted to opiates, it's a very strong predisposing factor is if they take an opiate and it activates them, they're much more likely to get addicted. So this is just a window into genetics, which is what we're going to talk about. I think that addiction is known to be between, the vulnerability to addiction is between 40 and 60% genetics. This isn't like on one gene, it's spread across many chromosomes and many different genes. So we haven't isolated it completely. But there's plenty of people who can use substances on a regular basis and they don't develop the neural pathways in the brain that lead to the compulsiveness of addiction. Because that's kind of the hallmark of addiction, is the compulsiveness of use and not just the use. There's many people out there who use substances and abuse substances and even develop consequences in their life that would therefore meet the criteria for a use disorder. But the question is, do they really have an addiction? I would argue some don't, right? And what is it that causes an addiction? These genetic factors. Well, there's some pretty cool literature that's coming out. There's a guy named Eric Nestler from Mount Sinai, and Terry Robinson and Kent Barrett from the University of Michigan, which is where I used to be faculty. And they're talking about this idea of incentive salience. So most people, most people's understanding of addiction has to do more with kind of pleasure and the pleasure molecule. And, there were two neuroscientists in the 80s, Roy Wise and George Koob, who came up with a theory that dopamine is the central molecule of addiction. And when dopamine is released into the reward circuit, it ends up causing pleasure. And so since then, this is where the narratives have been kind of described about addiction, that it's all about, dopamine causing pleasure. But, Terry Robinson and Kent Berridge, they challenged that. And their research is actually pretty old, too. It's from the 90s. But they feel that dopamine is more involved with something called incentive salience. And incentive salience is a term that they coined. And so the way that I remember this is I kind of reverse the words. So salience is a term for something that stands out. Much of what our brain does is actually filter out things that are not important to us. Like a high percentage of what our brain does is actually, determining what has salience. And so salience is if something has importance and it stands out to you. And the incentive part of the incentive salience has to do with motivation. So if something causes someone to act. So for example, if you remember the little squirrel from Ice Age, have you ever seen that movie?
Yeah, excellent film.
Yeah, it is. It's an excellent film. And if you think back, there's the acorn, and that acorn is the exact example of what has incentive salience to the squirrel. That stands out more than anything in the squirrel's existence. And it motivates that squirrel to do crazy things and to go into crazy, dangerous environments, right? So that acorn has incentive salience. Another kind of archetype of incentive salience is Anthony Bourdain, rest in peace, right? Exotic foods had incentive salience to him. They stood out to him more than anything, and it motivated him to travel around the world to find exotic foods. And so this is kind of like the newer theory of addiction, is that dopamine causes incentive salience. And the last piece of that I just want to riff on is that, with addiction, most people would agree that drug liking diminishes over time. Like the 1,000th time they've used heroin, most people will say, I don't get any euphoria from it. It just makes me feel normal, right? And so doesn't really fit with the whole pleasure molecule idea, right? But their motivation to find it again goes up and up and up, right? And so that's called sensitization versus tolerance, as you guys know, which is another good topic for the boards. It may be a little simplistic, but we'll just review it. Tolerance is very simple. You use a drug multiple times, it has decreased activity, you become tolerant to it. Sensitization is the opposite. The more times you're exposed to a drug, there's more effect. And the incentive salience aspect actually increases over time. So the more time that you're exposed to a drug, the more the dopamine gets released. And there's actually animal models that show this. It's really fascinating. And this fits with kind of the pattern of addiction.
So to return to the original Koob and Wise theory that dopamine's the pleasure molecule released into our reward pathway, we feel good, so we keep doing it, versus the incentive salience model. The first kind of puts the cause of addiction, if I understand this correctly, in the drug, the substance itself. And the other one this incentive salience model takes into account the dyad of drug and human being who takes the drug. Is that correct? Am I understanding this correctly?
Yeah, I think that's an interesting way to look at it. Another way to explain it is that dopamine gets released in response to pleasure, in order to remind the human being to create these circumstances again in the future, to motivate you to remember how to create these circumstances again in the future. So plenty of things in normal life, have incentive salience, and it's a natural aspect of being a human that gives us a competitive advantage to survive and procreate. So as with many things in psychiatry, addiction is just an exaggerated form of a normal process.
Well, on that note, then, addiction, the term. So if I'm correct, that is not how the DSM-5 conceives of this problem, right? It's more so in terms of substance use disorder, and then the unique outlier amongst behaviors being a gambling disorder. Is that correct?
Correct.
So can you be addicted to behavioral type activities like pornography or gambling, which, yes, I think you psychiatrists say that gambling's a big yes. What about those things? Like, is addiction just substances? I know that's a leading question, but
Yeah, no, I mean, absolutely. Earlier on in my psychiatric career, I wasn't convinced that like internet gaming disorder was real or behavioral addictions were real. But the more I do this, they are absolutely real. What defines an addiction is if it's chronic and progressive, and it gets to the point where it's causing disruptions in their life. And for example, with internet gaming disorder, there are people out there who are inserting Foley catheters so that they don't have to go to the bathroom to urinate so that they can play for 16 hours straight. They've lost their jobs. They've lost their girlfriend or boyfriend. I mean, that's evidence of consequences and progression to the point of addiction. So absolutely.
Yeah, I could definitely see that. I think that would be something that would pull me in. Yesterday, I hadn't played video games in forever, and I spent like literally the whole afternoon playing with my son. Just an unscripted day, and that was fun. That was great. But man, the time went by like that. It was like 4 hours. Boom. How long was that? It felt like 20 minutes. So I definitely have to be careful with the old video games. But yeah, it's just interesting to me how little I think treatment options exist if you just Google these things for some of the behavioral addictions. It seems like that's another area that is in its infancy, not even its adolescence, perhaps.
I agree. And I think that, this is something where, there's a group of us on the inside of, academia who are starting to pay attention to other aspects of treatment. In my opinion, if someone has a true addiction, the only way to treat the addiction is through behavioral changes to create new neural pathways in the brain. And so I'll discuss that a little bit further. But don't get me wrong, like medicines are critical in the management of people who have addictions. They're life-saving, and I use them every day in my practice. But I think we have to be careful because, in my opinion, they don't actually treat the addiction itself. And there needs to be another component to it. Medicines are necessary, but in my opinion, not sufficient. Because now that we're getting into like what actually is addiction. So addiction is neuroplasticity. Basically, what dopamine does is it creates neural pathways in the brain that bypass the frontal cortex, that bypass our capacity to modulate our impulses. So we could go directly from impulse to action. And this is where Eric Nestler's work comes in. Dopamine increases the dendritic connections in certain pathways. So it reinforces some, and other pathways atrophy. There's this idea of competitive neuroplasticity that's been around for a while. It's kind of the use it or lose it. So if you're in these neural pathways where you bypass your frontal cortex, they gain momentum, and it's kind of the anatomy of a craving.
Interesting. Craving. What's that?
That's a simple question, but it's a great question. What really is it? We don't know. I mean, we have theories, and my theory is that these neural pathways develop in the brain that are kind of associations that have been created by dopamine in the past. So, for example, if somebody was wearing a blue shirt, and it was their favorite blue shirt, and they shot heroin for the first time, that's going to be neurobiologically associated with heroin. So the next time they use their blue shirt, that kind of jumps them onto that addictive pathway, which in the past has been associated with drug use. So there's going to be an impulse to use. So that's kind of like, in my opinion, the description of a craving.
Interesting. Yeah. This is so fascinating. I think addiction is definitely one of those fields that there's a lot of opportunity. Obstetrics is what I'm trained in. So I don't know how to put this because I don't want to sound critical of this specialty, but But it seems like, there's not going to be a lot of innovation it's true. There's not going to be a lot of innovation in how to deliver a baby, right? That's a natural process, and we've been able to reduce mortality and morbidity significantly, but like the process is the same, and the limits of inquiry are so specific now because there's been time, there's been money, there's been effort put into, investigating the labor curve or, the various drugs for the induction of labor. Addiction, it seems, as a field as a whole, like we haven't really worked out the neurobiology, the best treatments, and because as I've seen the terminology change just in my career in medicine. I graduated from med school in 2010. Like it still seems people are clawing at the appropriate language to use to describe the phenomenon. And that's why I would tell people, like, totally consider this as a career, because there's going to be a lot of interest. There's a lot of areas that will develop. This is what I tell people about psychiatry too. It's really coming into its own as far as a scientific field. I don't know where I'm going with that, but yeah.
I agree. Yeah. It's a fascinating field to be in. And things are changing all the time. Like here at OHSU, we developed a new protocol for kind of micro-inductions onto buprenorphine that, was published. And I believe it's kind of like changing the course of practice, which is really exciting. And so this is, it's great to be in a field where we're making changes that are going to be generalized. So it's a great field to go into.
Yeah. So you mentioned micro-induction protocol. So why is that important? What do you mean micro-induction? Why can't you just, if somebody has an opiate use disorder, just give them some buprenorphine and call it a day?
Well, it's because oftentimes the process of getting people onto the buprenorphine can be challenging. Some people can't tolerate the withdrawals. If people are on methadone, for example, the transition to buprenorphine is really hard. They have to decrease the dose, and then they have to be abstinent for a couple of days at least to not precipitate withdrawal. Because precipitated withdrawal is a great question for the boards. I suspect most people probably know what it is, but natural withdrawal from any substance, for example, from opiates, happens slowly over time. The full agonist molecules just slowly dissociate from the receptors over time, and then you slowly go into a withdrawal syndrome, and it progresses slowly as time goes on. Precipitated withdrawal is when you have another molecule that jumps in there. It's a bully. It rapidly shifts all of the molecules that are already on, like the full agonist opiates that are on the receptors, off the receptors because it has a higher affinity, and you have this rapid physiologic shock. And that's what precipitated withdrawal is. Classic opiate withdrawal is not dangerous, period. Precipitated withdrawal is dangerous. There are case reports of deaths, lots of bad things happening. So this is another important thing to know about for clinical practice and also for boards. Precipitated withdrawal can be dangerous. But anyway, a microinduction just kind of slowly introduces small amounts of buprenorphine, which has a higher affinity and is a bully molecule. So it just kind of slowly dissociates the full agonist from the receptor. So people can actually stay on their full agonist opiates all the while that the buprenorphine is being titrated up. It's brilliant.
Interesting. Just curious, what do you guys do?
So like, for example, if somebody's on 90 milligrams of oxycodone, they continue on their oxycodone while they're starting with the microinduction. They're given like 0.5 milligrams of buprenorphine on day one, a milligram on day 2, 2 milligrams on day 3, and kind of like that up until they get to day 5 or 6, while they're still taking the full agonist opioid. And then all of a sudden you hit about 8 milligrams. Once you hit 8 milligrams, then you could just completely stop the full agonist opioids.
Interesting. Recovery. So the term used for people battling addiction. See, this is also why I like the field, because you are, as a physician, contributing to recovery. There's medical treatment that we provide, but that is not the whole story in helping these patients. And that's why they talk about being in recovery. So let's move to the philosophical, I guess. So it seems to me that people can get the cravings taken care of for their opiate use disorder, for instance, with methadone or buprenorphine. But that doesn't necessarily mean they're not going to, completely stop using heroin, fentanyl. They occasionally do, or there's some stress trigger.
Amphetamine or benzodiazepines or other drugs,
Correct. Actually, that's I didn't want to get things too complex, but that is the thing that I think is tough, to look at addiction as more than just a biologic disease, but also a psycho-spiritual problem. Any thoughts on that?
Yeah, I think that
a relational problem as well.
Absolutely. You touched on so many important things, and I'll just start by, like recovery. There's a great term called recovery capital, which, it would be great for people who are curious to look it up. And it's basically a description of positive aspects of people's lives that can be kind of quantified as the more time they spend in recovery and abstinence. And it talks about how are your relationships going? Do you have a job? Just all of the positive aspects of your life. And so I think we need to start thinking of recovery as something more than just not using drugs. And this also does tie directly into the neurobiology of it, because again, what's the cause of the addiction? Well, it's these neuroplastic changes in the brain that bypass the frontal cortex. So even if you stop using drugs, you could be using those neural pathways in the brain. So you have to build a separate set of neural pathways. And how do you do that? You do that through doing enjoyable things in recovery. So if people start a new hobby and start to feel contented and joy over and over again, they're causing normal endogenous dopamine release in the system that's building these recovery pathways. And so that's kind of the exciting part about this neurobiology of recovery, is how do you do it? You find ways that are different from the old pathways, right? Because if things in the past got so neurobiologically associated with a drug, like for example, if every single time somebody went fishing, they were drunk on alcohol, then fishing probably isn't a great one to use as a new hobby in recovery, because it's going to be so neurobiologically associated that when you go fishing, it's going to bring you into those pathways. So maybe pick up a new hobby and feel contented over and over and over again, and build these recovery pathways in the brain.
How do you do that for people, or get them to see that? Because there's often like just a complete absence of hope. And if you have no hope, you can't really have any motivation. So, if you're coming to treatment for addiction, often you've got a pretty good measure of anhedonia there too.
Well, that's why I'm a big proponent of recommending people they go to 12-step groups and like AA and NA, is because they can have exposure to people who have come out the other end of this and are just living a life that is reflecting joy. And so I always am confident when I'm explaining to patients about this, that yes, your life will be better if you could just continue to do this. And they will listen to me to some degree, but they will listen much more to somebody who's been in the process and who has come out the other end. And so that's why I'm a big proponent of those self-help groups.
Yeah, especially.
And it also, I'm sorry to interrupt, but I have to say one more thing before I forget, because you mentioned how isolation is part of addiction. It's part of what happens. The people who are genetically predisposed to addiction are genetically predisposed to isolation. And that's one of the most destructive aspects that goes against recovery. And that's another reason why some of these self-help groups are great, is that it's a way that people can kind of get outside of themselves and outside of isolation and into some sort of group dynamic. Because somehow there's something also, as a psychiatrist, there's magic that happens in groups. When people are able to be vulnerable in a group setting, there's some really cool psychodynamic stuff that's happening.
Yeah, totally. Yeah. Maybe I'll get around to writing some sort of philosophy of addiction at some point. probably when I retire. What about this phenomenon of replacing one addiction with another? I've heard patients or other people say, treat one addiction, people just replace one addiction with another. Does that happen? Is that a phenomenon that is supported by research, or just kind of a gestalt that gets bandied about?
Well, I call it the whack-a-mole phenomenon. And if you know that game, the whack-a-mole, where you hit one mole and another one just pops up, that's kind of the way it works. And you're right, it is real. It's been documented in research that people will shift from one addiction to another. From my experience, oftentimes people will have a primary addiction, something that really gets them, that's really their favorite thing. And that's kind of their drug of choice. But those people absolutely will switch from one addiction to another. And this is one of the sad progressions that I've found, is that oftentimes it's almost like the final common pathway is methamphetamine these days. And that's just a trend I've noticed. And methamphetamine is definitely the most destructive of the drugs. It's so powerful. It causes, like, for example, cocaine causes 300% of your natural dopamine release. Methamphetamine causes 1,200% of the natural. So, it will progress to addiction so much faster with methamphetamine. It's a term called telescoping, which might come up on the boards. It's how quickly you go from first drug use to like severe addiction.
And methamphetamine's velocity is a lot quicker because of how hard it hits the system.
Exactly. It has like quadruple the amount of dopamine release than the other substances.
What about then? I don't want to keep you too much longer because I know your time's valuable, and we all appreciate it. But when a patient comes, let's say, for treatment for an opiate problem, like 99% of them also are dependent on nicotine in some form. Should patients quit everything, as it were? Focus on one thing? Is there any advice on counseling patients to that end?
There's mixed data on this. Some people support that with, like, for example, with smoking, that just continue your smoking and get rid of your primary addiction first. But there's also other data that shows pretty distinctly that if they quit everything at once, then their likelihood of relapse is much lower. I tend to fit into that category. So if they're ready to quit, let's help them with everything, because smoking is a very addictive substance, and it kind of brings you into those addictive pathways. So, anything that brings you into those addictive pathways has potential to bring you back to your drug of choice.
Yeah, absolutely. All right. Well, I have so many more things I could ask you, and I'd love to continue this conversation. But before we end here, is there anything else really important that you'd want to communicate to students as they think about addiction, as they progress through training and hopefully acquire a greater appreciation of addiction as a disease so they can help patients?
Well, I would just say that addiction is a chronic, progressive, and fatal disease. And we have to think of it that way. So, for example, if people have had 10 episodes of care, that doesn't mean that they don't deserve an 11th or a 12th. There was a study that showed that it's on average, it takes people 11 attempts in order to get recovery. So have patience for these people. The other thing that I would say is that they're full-fledged human beings. Oftentimes people think of people of addictions as some sort of lesser form, because they oftentimes are really not nice people and steal and lie. And so it's a natural inclination to think that they're not great people. But it's the addiction that is causing a lot of these behaviors. And oftentimes, once the addiction is treated, people with addictions turn out to be some of the most amazing people you'll ever come across. So, and that's kind of why I can do what I do. And to witness these transitions is really, a privilege and a pleasure. And, I think that I also think that people who are predisposed to addiction are people who are, in a way, like super sensitive souls, that they may actually feel deeper and harder than others. And the addiction is kind of like a capacity to tolerate all of these, emotions. And so once they're able to learn ways to kind of modulate their emotions, they can be really super remarkable people.
Yeah, cool. Well, thank you. I 100% agree with that. And again, thank you so much for your time.
You're welcome.